And thank you to our witnesses here today for sharing your insight and your recommendations. As well, I'm concerned about the sustainability of Medicare and want to look at not only the short-term but the long-term solutions so that we can see Medicare in a more sustainable fashion. We know that there's a large difference in terms of delivery to urban areas compared to rural areas. Obviously, I represent a very rural constituency, and I want to ensure that changes we make to Medicare do not further limit access to critical services to people living in rural areas. Mr. Miller, when MedPAC was looking at ways to reform payments to post-acute care services, did you research whether these reforms would impact access to our rural communities, and if so, how?
We did, and we recently, I think it's in June 2012, did a fairly extensive report on rural services, access, quality, that type of thing. And when you look at service use, whether we're talking about physicians, hospitals, skilled nursing facilities, home health, ESRD, drugs, we looked at a range of different things. The utilization rates between urban and rural areas are not all that different. The only real place that we found a difference is in the most frontier counties of the country. There is a lower home health utilization rate, but everything else, pretty consistent.
Can you elaborate on most frontier counties?
If I may get this wrong, I think it's 6 persons per square mile, something like that. And I may have that all wrong, but I can tell you, just not this second. Okay.
Thank you.
The thing to keep in mind that I want you to get across to you and the committee, it's not about urban and rural. If you go to Louisiana, the highest utilization rates in the country are in Louisiana, Texas, areas like that. It's urban and rural. If you go to South Dakota, you have low utilization, urban and rural. It is much more a phenomenon of practice pattern and sort of entrepreneurial service utilization than it is an urban and rural phenomenon. And I just want to get this last thing in here. I'm sorry, I know you want to go again. But you know, our view is if you find a problem and you think that there's an access issue, target the solution to that as opposed to saying, okay, here's a payment for anybody with rural in their name. And then, you know, for example, in home health agencies, the rural margin is actually higher than urban. So our point is really about targeting it to access problems. Sorry.
Okay, thank you. Mr. Bloom, in your opinion, would any of these proposals be detrimental to providers in rural communities?
I think we always have to be mindful of that and to make sure that beneficiaries throughout the country have access to quality services. As Mark said, home health, for example, that we see high margins consistently throughout the entire industry, for-profit, non-for-profit. So that gives us confidence that we can lower payments without compromising quality of care. But I think it is a fair demand that Congress should put on the agency to monitor what happens to beneficiaries real time with these payment changes. I talked about the work that we've done on DME, dialysis care, for example. So I think if Congress were to adopt these policies, one recommendation that I would have is for Congress to demand CMS to monitor what happens real time to make sure the quality of care throughout the country is not compromised.
Okay, thank you. I yield back.